Hello, everyone. I'm Dr. Carmen Puliafito. I'm here with Dr. Nikolas London of the Retina Consultants of San Diego Group, also Chief of Ophthalmology at Scripps Memorial Hospital in La Jolla. Nick, welcome to Retina Synthesis.
Hey, Carmen. Thank you so much. I'm very honored to be here.
So today we're going to talk about suprachoroidal gene therapy for neovascular AMD using the RGX-314 vector from REGENXBIO. So can you tell us a little bit about where we're at with this clinical trial?
Absolutely. So this is a very exciting trial. So this is a phase 2 multi-center study that's being done at about 15 sites across the US. It's currently enrolling. It's a study made of 5 cohorts with 2 dose escalations in the middle of those cohorts. And we're now enrolling into cohort 5. So we've fully enrolled in cohorts 1 through 4. And we have some preliminary data that's been presented on the first 2 of those cohorts. The study involves treating patients with previously treated wet AMD. So these are patients that we see in our clinic receiving injections. And we offer them enrollment into this study, which is a study looking at using gene therapy, RGX-314, which uses an adenovirus vector to get a small episome into the tissue of the eye, which actually encodes for a protein that's very similar to ranibizumab, which is one of our more commonly used anti-VEGF injections that we have available. So we've presented some data. I presented data at the recent Retina Society meeting in early October on cohort 1, and Bob Avery then recently presented data on cohort 2, 6-month data at the American Academy of Ophthalmology meeting just recently in New Orleans.
So the patients that were enrolled, how dependent were they on injections at the time of study entry?
Yeah, these were patients that were very dependent. So the average annualized injection frequency was like 8.8 injections, I believe, over the past year. These patients were receiving about every Q6 to 8 week injections prior to study enrollment.
So what's the rationale about using suprachoroidal injection for gene delivery?
To me, that's one of the most exciting parts. I mean, so we can do gene delivery in the subretinal space. We're pretty familiar with those subretinal surgeries that involve a bleb formation. We see it with Luxturna. We see it in some of our geographic atrophy studies, as well as some of our other wet AMD studies, including RGX-314, which is being looked at in the subretinal space with Atmosphere. Suprachoroidal treatment brings the treatment into the office, which to me is very exciting and more palatable to a lot of our patients. So using the Clearside needle, which is a 0.9 or a 1.1 millimeter needle, we can do the injection in the office and get the gene therapy product into the suprachoroidal space with a very easy and essentially painless or minimally painful injection in the office. And all we really need to do with a product like this is get it into the tissue of the eye. The gene therapy product doesn't need to be made essentially close to the macula, just like our intravitreal injections. The protein just needs to be into the eye and it will get to the macula. So if it's being produced anywhere in the eye, it should get there.
So tell us about the initial study results.
So in cohorts 1 and 2, which are the study results that have been presented so far, we've seen some pretty impressive results. So in terms of efficacy, so we've seen very stable central retinal thickness over the course of 6 months in the study following study enrollment, and very similar to the patients who were in the control group. Those patients were treated with monthly ranibizumab. And we've seen very stable visual acuity results with essentially in cohort 2, no change in visual acuity following study enrollment from day 1 at the very beginning of the study, which is very similar again to the monthly ranibizumab patients. We've seen good safety results. So we've had your normal kind of intravitreal injection or suprachoroidal injection in this case with subconch hemorrhage, erythema, things like that are sort of common that we expect irritation. We've seen some cases of intraocular inflammation, and that's something that as a group, all of us retina specialists are very concerned about intraocular inflammation, and appropriately so, given other things that we've seen recently. And we've seen about 25% of the patients treated so far in the first two cohorts, but they've all been mild. They've all been 1 to 2 plus, and they've all resolved within days to weeks with a topical corticosteroid. And one thing to keep in mind with this study is that nobody was on prophylactic corticosteroids. So there were no systemic or topical corticosteroids in this study whatsoever. So these patients developed a mild anterior chamber cell for the most part, one patient with a mild vitreous cell. All were put on topical prednisolone or similar, and all resolved. There were a couple cases of episcleritis in cohort 2 that we're kind of looking at, and that again, for the vast majority of patients, resolved very quickly with topical corticosteroid. In cohort 2, those patients received 2 injections. So that was a doubling of the dose from cohort 1, from 2E11 to 5E11 gene copies. And so we wonder if with that 2 injection technique, if that's why those patients may have developed this transient episcleritis. But all of my patients, at least that had it, are doing very, very well. No concerning inflammation, no severe cases of inflammation in any patients whatsoever. And probably the most exciting thing of all is the reduction in the injection frequency. We've seen about 75% reduction in the annualized injection frequency in the first 2 cohorts. Cohort 1 was about 76% reduction in injections. And cohort 2 was about 70% reduction. And about a third of patients in each of these cohorts were injection free. So these patients went from receiving injections every 8 weeks prior to study enrollment, and these weren't cherry-picked patients by any means. And these patients, a third of the patients in the study, received no further injections over that 6-month period. So all in all, I'm very excited about these results. I can't wait to see the higher dose, and I can't wait to dive deeper into the data in some of these, but I think it's going to be a really big game changer for a lot of our patients, and I'm very excited about it.
Are all of the cohorts fully enrolled yet or not?
So the first 4 cohorts are fully enrolled, and we're working on cohort 5, which is the last cohort. So I don't know the exact number, but I'd guess there are about 15 slots left, or 15 patients to enroll.
So these are the cohorts simply vary by drug dose. Is that correct?
For the most part. So the first cohort is that 2E11 gene copies. Cohorts 2 and 3 are the 5E11, so doubling. And cohorts 4 and 5 are 1E12, so another doubling of the gene copies. Within the second and third cohort, the cohort 2 is NAb negative, so neutralizing antibody negative for adenovirus. And cohort 3 is NAb positive, and the same thing for cohorts 4 and 5. They just vary. They're the same dose, but they differ based on the gene copies. I'm sorry, the NAb positivity.
Mm-hmm. And what do you mean by NAb positivity for?
So neutralizing antibodies. So they're wondering if patients that have been exposed to adeno associated virus may have a different response to the gene therapy product. So if you have pre-existing preformed neutralizing antibodies to adenovirus and you're treated with a gene therapy product that's delivered by an adeno-associated virus vector, will you have a different response? And so they're looking at the difference there and seeing if those neutralizing antibody positive patients have that different response.
In terms of reduction in injection frequency, how similar or different are these results compared to the subretinal gene delivery?
So I don't have the numbers exactly. I don't think we know the numbers. We may have from the phase 1/2A study some data, and I think they had an impressive reduction in the injection frequency. I think we expect a more potent response with the subretinal delivery, which makes sense to me. You're sort of delivering the product into the subretinal space as opposed to the suprachoroidal space, so you will likely get a more prominent response, but I don't know the exact difference in the reduction in injection frequency.
So what's the next step for this treatment, do you think, Nick?
Well, we're again, we're going to finish enrolling this. We're going to dive deeper into the data. We're going to look to see if the second doubling of the dose has an even more potent effect. If we see a 76% reduction in these initial doses, are we going to see an even more impressive reduction? This is a 1-year study, and then we're going to do a long-term follow-up to see what happens over the course of time. I think a lot of people are a little bit wary of gene therapy given the potential long-term changes that we may see and hopefully not see. So we're going to be following our patients for many years and see what happens. We're again starting to enroll now in the Atmosphere study, which is the subretinal delivery study. I think it's going to be fascinating, as you've already alluded to look at the differences between suprachoroidal delivery and subretinal delivery. I personally really enjoy the suprachoroidal technique, and I find that my patients, if I'm enrolling in both of them, and if I give them the choice about which to be involved in, they're much more excited about the suprachoroidal. But we'll see. I mean, if you're right, and we see a more potent response with the subretinal delivery method, then that may change that. It sort of changes how you describe these studies to our patients. So, we got a lot of data to still collect, a lot of analyses to perform. We need to, make sure that this is a safe product. It looks very safe so far, but we need to look deeper at these cases of episcleritis and intraocular inflammation, which seem to be a kind of a non-issue at this point, but we first priority is safety for our patients, so we need to make sure of that.
Well, Nick, thanks so much for joining us on Retina Synthesis, and we'll be back to you later next year to find out what's going on with the long-term results from this really important study.
Thank you, Carmen. It's really an honor to be on this with you. Have a great day.
Thank you.